Good afternoon. Welcome to the Zoom WCSA vaccine talk. Today we have a special guest. His name is Dr. Gregory Buller. He received his undergraduate and medical degrees from the University of Kansas, go Jayhawks, and then completed his internal medicine residency, chief residency fellowship training at Duke University. Very nice. Where he was also on the faculty. He subsequently came to the Yale system, where he currently is clinical professor of medicine, chairman of the Department of Medicine at Yale New Haven Health, Bridgeport Hospital, and associate chief medical officer. He has received more than 20 Yale teaching awards, as well as the American College of Physicians George F. Thornton Award for Teaching Excellence, and is the author of more than 100 scientific articles. Dr. Buller is also a former professional tennis player and an avid skier and road racer. Has a fantastic background. We are very honored to have you here.
Thanks a lot, Jason. Appreciate it. So what I'd like to do is maybe give you all a little bit of background on the history of vaccination for maybe a minute, and then, cover the various vaccinations and recommendations from the Centers for Disease Control, or the CDC. And then certainly entertain questions. If you have any questions, feel free to put them into the Q&A or the chat, either one. So first, one of the top 3 or 4 discoveries in the area of medicine is vaccination. And I'm not sure, age-wise, if any of you can remember active polio, or you knew individuals who were on an iron lung. I certainly had patients early in my career who had a history of polio. And the development, that was scary to everyone. I remember as a kid, I was, concerned I might catch polio. And then they, of course, came out with a vaccine. The vaccine that I took was actually a sugar cube. I didn't even have to get an injection. So that was a huge, huge advance in medical care, and has, for all intents and purposes, eliminated polio from the landscape. A much greater problem was smallpox. And smallpox has been declared eradicated from the earth, totally as a result of vaccinations. Now, there are still some laboratories that are studying smallpox and have smallpox, virus there. But diseases have been eradicated from mankind that have caused huge numbers of death and associated medical illnesses through vaccines. So it's hard to overemphasize the importance of vaccination. So in that setting, let me just kind of go through kind of the main ones that affect, I think, most of the individuals who, are on this, this Zoom. And I'm going to start with COVID because that's top of mind for everybody, and kind of go through that. And then I'm going to hit shingles vaccine, zoster, and then of course the flu vaccine, the pneumonia or so-called pneumovax vaccine, and then a few others like hepatitis and some others, and very briefly touch on travel. And again, if you have any questions going forward, just certainly, feel free to ask. So hopefully everyone who is listening to this at any given time has received a COVID vaccine. There is no more important vaccine to receive in the present population of people than a COVID vaccine. COVID has an approximately 1.5% to 2% death rate for those individuals who contract it, and that's just across the board. But then some individuals have a much higher death rate, particularly those who advance in age. So that death rate goes up markedly in individuals over the age of about 55. We'll see this kind of gradual rise, and then it goes up quite a bit. And that is really the biggest risk factor for death or severe COVID, hospitalization, what have you, along with some other risk factors, including, immune system problems, diabetes, obesity. And I'm almost certain I'm not telling anyone who's listening to this anything they don't know. And hopefully everyone has received one of the 3 FDA-approved vaccines, Pfizer, Moderna, or the Johnson & Johnson vaccine. The major question I would suspect everyone would have would be, what about boosters? So given my status as a healthcare worker, and I take care of COVID patients here at Bridgeport Hospital, I've received a booster vaccine to the Pfizer one, which was the sort of vaccine that I received. And individuals who are over the age of 65 or who have various types of immunosuppressive illnesses, or I should say immunocompromised, or on medicines that would suppress the immune system, all these individuals should receive a 3rd shot of the Pfizer vaccine, as well as the Moderna vaccine. Again, those individuals who have various diseases that predispose them to COVID. Now, as far as individuals who are otherwise relatively healthy, who are over the age of 65, or healthcare workers, for instance, who have received the Moderna vaccine, a panel has strongly recommended this to the FDA, and the FDA will likely formally approve that. Exactly what the dose of that Moderna vaccine will be, that booster dose, probably remains to be seen to some degree. But almost certainly, individuals who are over the age of 65, who are otherwise healthy, should receive a so-called booster shot of Moderna. Johnson & Johnson vaccine recipients, again, almost certainly the FDA will follow the guidelines of the recommending panel, and individuals who receive the J&J vaccine will get a 2nd shot. Would it be better for individuals who have received the J&J vaccine to get either a Pfizer or a Moderna booster? That remains to be seen. There's certainly some evidence that suggests that is safe and may actually be preferable, but that research data is somewhat limited. And likely what the FDA will recommend is that individuals who receive the J&J vaccine simply have a 2nd dose. I'm not really going to say a whole lot more about COVID vaccines unless there are questions. Understand that there are over 100 still experimental vaccines for COVID being developed across the world, which should be reassuring to everyone. That, for instance, if a new variant pops up that is relatively resistant to the present vaccines, hopefully there are other vaccines that are being developed, or using the present platforms can be developed to fight those vaccines. So why don't I then move on to other vaccines that individuals, and I'm going to largely confine myself, of course, to adults, and largely to individuals over the age of 65, that they should receive. And one of them is clearly what we call the zoster vaccine. Zoster meaning shingles. So the CDC recommends that anyone over the age of 50 should receive the zoster vaccine who is otherwise healthy. They should receive 2 doses of the so-called Shingrix vaccine, and the 2 doses should be about 2 to 6 months in between each dose. So it's some variability. So if you don't get it exactly 2 months, you have all the way up to 6 months. And if for whatever reason you don't even get it at 6 months, you certainly still get it. But ideally, you want to get the 2nd shot between 2 and 6 months after you receive the 1st shot. Importantly, so why does everyone need a shingles vaccine? The reason is that if you've been exposed, like the 99% of individuals over the age of 40 to chickenpox, whether you knew you had it or not, because a lot of it's relatively asymptomatic, then the chickenpox, generally your immune system deals with and eliminates it symptomatically. But what happens is it kind of hides in areas of the body, in certain nerve, what we call ganglia, and your immune system kind of keeps it at bay for the majority of your life. But unfortunately, as we age, our immune system gets a little bit iffy, and it can drop down intermittently. certainly depending upon how much stress we're under, other medical problems we have, et cetera. And that can allow then the dormant chickenpox to then move along nerve endings and cause shingles. There are kind of three main problems with shingles. One is it can cause blindness if it involves the eye. Secondly, of course, it causes a lot of pain in a lot of people. And that's really variable from person to person. Some people, a lot of pain, other people, not so much pain, just depends on the person. Generally, what happens almost always is that then again, your body's immune system comes up and deals with shingles and it resolves over the course of time, usually a few weeks. The bigger problem then is what we call post-herpetic neuralgia. And what that is that even though the shingles may have completely disappeared from any expression over wherever it was, you still may have symptoms. You still may have ongoing pain. And that can be, really pretty significant for individuals, and it can last for the rest of one's life. So to prevent this post-herpetic neuralgia and to largely prevent shingles completely, it is extremely important for individuals, again, those individuals who are eligible are over the age of 50. So everybody over the age of 50 should really receive the Shingrix vaccine, the 2 doses. Now, this is whether you've had chickenpox or not that you remember, and it's whether you've had shingles or not. So even if you've had shingles, even though your body is certainly now relatively immune, it's not clear how long that's going to last. So you should still receive the Shingrix vaccine, irrespective of whether you've had shingles before. Now, there was a prior vaccine that is called Zostavax. Is not quite as effective as the current Shingrix vaccine. And even if you've had that vaccine, because it's not as effective as Shingrix, you should go ahead and receive the Shingrix vaccine. So virtually everyone, at least over the age of 65, should get the vaccine. Now, who shouldn't get a Shingrix vaccine? So this is true of any vaccine. If you are allergic to any part of the vaccine itself, for instance, if you've had 1 dose of Shingrix and you had some horrendous reaction, allergic type reaction to it, of course, you shouldn't receive the second dose. Or if you are going to get it, it should be under a doctor's supervision and maybe with some pre-medication. In addition, those individuals who have tested negative for immunity to chickenpox, in other words, that very small number of people who never have been exposed to chickenpox, they should not get Shingrix. Instead, they should get the chickenpox vaccine, which is a completely different vaccine that, of course, we administer kids. People who currently have shingles, they should not receive the Shingrix vaccine. So if you do have shingles, when should you get it? Well, generally, you want complete resolution of the shingles before you receive the vaccine. Certainly less than 3 years as a time period after you've had shingles. Pregnant or breastfeeding women shouldn't receive the Shingrix vaccine, and true of any vaccine, because rarely someone might have some side effects of the vaccine. If you have a moderate to severe illness, you really should wait until that illness is passed before receiving the vaccine. This is true of virtually any vaccine, to be honest. Now, what are the side effects? I mean, you can get pain at the site of injection, like with every intramuscular injection. You can have some headache, you have some fever, you can have some nausea. These symptoms are more common in younger individuals compared to older individuals. And like a lot of the vaccines, when you compare people who get the Shingrix vaccine versus individuals who just get water in an intramuscular vaccine, in populations of people, there's actually virtually no difference in anything symptom-wise between those two groups, except for the pain and maybe some redness at the injection site. That's a lot more common when you get the vaccine than if you get what we would call a placebo, so to speak. It's incredibly effective. It is 97% effective in individuals ages 50 to 69 in preventing shingles. It's a bit over 90%, not quite as effective, when you're over 70, but more than 90% effective at preventing shingles. And it's about 91% effective in all age groups at preventing this post-herpetic neuralgia. And if you do have post-herpetic neuralgia after receiving the vaccine, after you get shingles after receiving the vaccine, it's much more mild than it might otherwise be. Now, what about severe reactions? This is kind of like the COVID vaccines. Severe reactions are incredibly rare. They occur in about 1 to 2 per million people. I'm talking about things like what we call anaphylaxis, where you might get swelling of your lips and your tongue and your throat and have difficulty breathing, or really severe hives. Those can be life-threatening. They're very, very, very uncommon. Who pays for a Shingrix vaccine? Medicare D covers it, although how much you might have a copay, if any, kind of depends upon whether the kind of insurance coverage you might have. Unlike, say, flu vaccine, or I should say the pneumovax vaccine, Medicare Part B does not cover Shingrix vaccine. So much for Shingrix. The next most important vaccine, and maybe not in order of importance, but certainly one that every individual who's listening here should strongly consider getting, is an influenza vaccine or a flu shot, right? So this is approved by the FDA for everyone over the age of 6 months. Hundreds and hundreds of thousands of individuals are hospitalized due to flu. There are tens of thousands of people who die, excuse me, due to flu or complications of the flu, like things like what we call a superinfection with bacteria causing pneumonia. There are a multitude of influenza vaccines. Most of them are what we call quadrivalent. In other words, they protect against 4 different types of influenza. This diversity of the various vaccines really allows one to kind of, individualize it as to what's most appropriate for you. Now, a lot of this individualization has to do a lot with age and, excuse me, whether someone's pregnant or not, and what other diseases they have. So I'll just kind of mostly, concentrate on individuals over the age of 65 as to, what should be done. So the way influenza works is that it kind of starts in the southern hemisphere and then kind of moves its way towards North America. So we always get an inkling of what's going to move towards North America from what's going on in, say, Australia, New Zealand, to a little lesser extent, parts of Asia, Japan, China. And we identify what then the prevailing type of influenza is, and then the vaccine is manufactured on that basis. Excuse me. It works for, generally no longer than a year. And of course, the type of influenza is changing year by year. So as I'm sure everybody here knows, you really need an influenza vaccine every year. How well it works, its effectiveness is totally dependent upon whether it actually fits the specific influenza that's circulating in any given time. So it ranges anywhere from 40% to 80% effective. Again, totally dependent upon just what's circulating in one's own community or of course country in general. So when I say 60 to 80% effective or 40 to 80% effective, that really is at preventing significant influenza. So it markedly reduces the incidence of any hospitalization or having to be in an intensive care unit or certainly dying as a result of influenza. And it reduces that risk, many fold. So who should get vaccinated? Everybody, virtually. So I'll really concentrate on who shouldn't get vaccinated, which, are again, only individuals who have a severe life-threatening allergy to prior vaccine. Now, unlike COVID vaccines, a significant number, but not all, of influenza vaccines are virus that is grown in egg culture. And then that virus is either killed or what we call attenuated. In other words, knocked down to some degree, and there's still some live virus there. Now, when I say that, what an influenza vaccine cannot and will not do is give you flu, okay? That absolutely does not happen. But if you're allergic to eggs, then certainly the usual flu vaccine is something you do not want to get. But on the other hand, there are alternatives, and you need to let your doctor or whoever you're going to get the influenza vaccine from know that you're allergic to eggs and that you need an egg-free influenza vaccine. So not only are some other virus grown in eggs, they can also be grown in what we call cell culture that has no eggs in it. And these are by and large, again, live attenuated sort of viruses, but they offer a lot of what we call immunogenicity. So they stimulate your immune system quite well. Whether you can receive a live attenuated virus vaccine or whether it has to be killed virus kind of depends upon then, a number of things. So, if one is pregnant or is going to be around pregnant individuals, or whether you're immunocompromised or around immunocompromised individuals, then you can't receive the live attenuated form of it. But again, there are multiple different types, and for your own particular situation, it's something worth checking with your primary care physician or whoever is going to administer the vaccine to you. So, excuse me. So what kind of side effects can one expect? Again, every injection, you can have pain at the site of the injection. You may have some headache, some fever, fatigue, etc. But again, in studies done also looking at a placebo injection versus a flu vaccine in populations of people, the only thing that differs between the two groups is some more discomfort at the site of the injection. There is a rare apparent complication of influenza vaccine and possibly of the J&J COVID vaccine, and that's what's called Guillain-Barré syndrome. So certainly if you've had Guillain-Barré syndrome in the past, within several weeks of receiving any kind of vaccine, then you should not receive the influenza vaccine. This is, again, one of those kind of 1 to 2 in a million sort of things. And it turns out that just what we call the background rate or spontaneous Guillain-Barré syndrome may occur 1 to 2 in a million anyway. So again, exactly how closely it's related to these vaccines remains unclear. But likely, if one has experienced Guillain-Barré in their lifetime, that would be a relative contraindication to receiving the influenza vaccine. So a slightly or kind of associated vaccine is the Pneumovax, so the pneumonia vaccine, because again, it's related insofar as influenza affects certainly the respiratory system, as does pneumococcus. So that's the specific bacteria that the Pneumovax prevents. It's called pneumococcus. There are a couple general different types. What we're worried about is what we call invasive pneumococcus. That's the kind that can, if invasive sounds bad, it is. It is life-threatening, primarily through pneumonia, but it can cause what we call septicemia. It can circulate throughout the body. It can cause organ failure, not just pneumonia. It is the most common bacterial cause of pneumonia. And it has a high prevalence for young children and also for adults who are over the age of 65. This is a bit more complicated than some of the other vaccines. There are, again, a couple of different types. One that's, well, so let me step back for a second. Pneumococcus has several different subtypes. We call these serotypes. And there are literally hundreds of them. And we try to prevent via vaccine some of the most common types. So there's one that affects or tries to prevent 13 different serotypes. So of course, you know, it's called 13. And then there's the one abbreviated PCV 13. And there's another one that does an additional 23, PPSV 23. So in general, at some point, individuals over the age of 65 should receive the 23 kind and likely should also receive the 12. And so this is generally, you receive the 12, you know, a year later, the 23, and then kind of depending upon the situation, 5 years later, you know, another dose. A lot of this depends upon just if you have any immune system problems. Again, it's best to check with your own personal physician about the pneumonia vaccine as to which one is best for you. But I would strongly advise everyone here who is over the age of 65 to receive a pneumonia vaccine. So how effective is it? Well, it's very effective for those specific serotypes of pneumococcus for which it's used. So it won't prevent all pneumococcus. It'll just prevent those specific serotypes. But again, these are the most common ones and the ones that most commonly cause really severe disease. So it's very effective at preventing those problems. One thing that also, especially in individuals over the age of 65, that you have to be cautious about are people who have cochlear implants. This is true for influenza vaccine, Shingrix vaccine, certainly the Pneumovax. And if you have cochlear implants, you definitely need to check with your personal physician about the appropriate type of vaccine that you should receive, because it varies in these individuals. Moreover, if you have various medical problems that cause suppression of your immune system, or you're on medicines that suppress the immune system, again, particularly, for instance, with Pneumovax, which particular vaccine and how many doses and how long you wait will vary. And it's probably not worthwhile because nobody's going to remember if I, go through all the variables here. But certainly, if anybody has individual questions, feel free to ask them.
We do have a couple of questions in the chat box.
Okay.
Go ahead. And one opt to have blood work done to see if they still have the antibodies to COVID instead of getting another shot?
No, absolutely not.
Okay.
There are numerous antibody tests. None of them are particularly good at delineating exactly how much immunity you may have against COVID. Whether they're low or high doesn't really tell you a whole lot, because there are multiple different subtypes to the immune system. And what we draw conclusions from what we call outcome studies. In other words, you get the vaccine and we see if you get COVID. It's kind of the bottom line. And we really don't look at whether antibodies are present or not present when we give subsequent doses. Now, a number of short-term studies look at antibody response, we call neutralizing antibodies. And the beauty of that is you don't have to wait for a period of time to kind of see what happens. You can, see what happens over the short term. But what we do know from studies in Israel is individuals, for instance, who had received the Pfizer vaccine, that after 6 months, it appeared that there was an increasing number of people who'd received the vaccine who were contracting COVID. And although, again, the vast majority of these individuals did not have severe COVID and weren't, hospitalized due to COVID, there appeared to be an increased incidence. Now, what we also know is people, when studies are done with the best of the antibody tests, is this neutralizing antibody concentration falls, and it falls after, somewhere around 6 months, the level starts to fall. But again, you also have this other kind of immunity that sits there in the background, which we've actually studied here at Bridgeport Hospital in conjunction with our partners at Yale, that shows that there's still a significant amount of what we call cellular or memory immunity, so to speak, to to COVID after vaccines or after the infection itself. So it's really more complicated than just checking antibody tests. So my strong recommendation is that one goes with the CDC and FDA recommendations about receiving boosters and don't mess with trying to measure antibodies, because it's just not going to be worthwhile. Yeah.
I've got one more. Can I socialize with my grandchildren right after I get the Shingrix vaccine, or do I need to stay away from my grandchildren if they've had the chickenpox?
If they've had chickenpox, you're good. No problem. Or if they've had a chickenpox vaccine. But if you don't know for sure if they've had chickenpox or not, and they haven't had the chickenpox vaccine, you should stay away from them. You should, for a period of several weeks, you should stay away from pregnant women. You want to stay away from anybody with any immune system problem. Any other?
What about travel? Any vaccines I need to travel right now?
Right. So I'll get to that in just that's certainly, a good question for those people who are lucky enough to be able to travel. So if you're traveling to New Jersey, A, I feel bad for you, but B, you don't have to worry about any kind of extra vaccines. But I'll get to that shortly. So, what are the other vaccines that one would consider, as possibilities that it might be worthwhile to receive? So there are hepatitis vaccines. These are individuals who have chronic liver disease and immune system problems like HIV, for instance, and individuals like that, or healthcare workers should receive hepatitis A and hepatitis B vaccines, particularly hepatitis B. Then there's the so-called MMR, measles, mumps, rubella. If you were born in 1957 or later, with no evidence for immunity, and this is where you would check antibody levels, then it's worthwhile receiving that. But if you're born before 1957, you really have no indication for that, certainly not at this time in your life. And then tetanus, or the tetanus, diphtheria, pertussis, TDP vaccine. A lot of that is more based upon tetanus and whether you've had wounds, and then how many tetanus vaccines you've received in your life. And certainly if you've received less than 3 tetanus boosters in your life and you have a wound that's worrisome and you haven't had your last tetanus shot in 5 years, then you need another tetanus booster. If you've received at least 3 boosters and you have some kind of wound, you don't have to worry about it even for 10 years after the last booster. So those are kind of very localized sort of things that, really are not standard recommendations. They may be targeted to particular individuals. Now, what about travel? So this is totally dependent on where one wants to travel to, of course, and what diseases are going to be prevalent in those areas. So if you're traveling to an area where you, for whatever reason, might be exposed to contaminated food or water. For instance, if you're a person who, likes to eat street food and for whatever reason is going to drink local water and not bottled water, then you really need to be vaccinated before you travel for hepatitis A, for typhoid fever, which is borne by salmonella, and cholera, depending upon, again, what's going on in the area to which you are traveling. If you're traveling to Canada, for instance, there are no, indications, or to, areas of Western Europe, et cetera. But on the other hand, if you are, going to travel to an area where you're going to crawl through caves a lot, or do any kind of, adventure expeditioning, you may want to actually receive a rabies vaccine. Anywhere you might be around bats or around other animal saliva, come in close contact, then you really should receive a rabies vaccine. If you're going to areas of, say, South America or Africa, sub-Saharan Africa particularly, then things like yellow fever are, particularly disturbing. You have to undergo a meningitis vaccine if you're going to Saudi Arabia, or again, areas of sub-Saharan Africa where there's tons of this certain bacteria called meningococcus that causes meningitis. And certainly if you're traveling to anywhere that has a lot of malaria, then you need not a vaccine, but you need some medicines. Now, I say not a vaccine, but just recently a study was released that has incredibly excited us that shows a vaccine for malaria prevents malaria in children in areas where malaria is prevalent. And understand that the biggest killer in the world is likely malaria, mosquito-borne diseases. So it may well be here in the next few years that a vaccine to malaria will be prevalent and available, which would be huge. Again, mosquito-borne illnesses, yellow fever, Japanese encephalitis, we have vaccines to those. And, you're traveling to again, to Africa or South America, or for yellow fever or for Japanese encephalitis, kind of what it implies. You're traveling to the Far East, the Pacific, Western Pacific, then it's probably something to at least think about. In general, though, you're not going to remember probably most of this, which is if you are going to do international travel, you need to contact a travel clinic. Certainly, we can put you in contact here at Bridgeport Hospital or in the Yale Health System in general with specific individuals who can administer all of these vaccines if necessary, or give you advice as to what vaccines or what medications, like for instance for malaria, you should receive or be taking. I think I've hit most of the major, vaccinations.
Two more questions.
Sure.
Come in. One was about mixing vaccines for COVID, the Moderna and the Pfizer, and the other one was about spacing them out. How far along do you need to go with that?
Yeah. So there is some data suggests that you can have an influenza vaccine, a COVID vaccine at the same time. You just different arms. They're not as yet included in the same vaccine. Maybe next year it'll be different. But I wouldn't advise it. It's just, kind of variable as to, just one's reaction to these vaccines and COVID more so than influenza. Most people are just not going to have any significant reaction to influenza other than their arm is hurting a bit. And COVID is just variable. I had my third booster back a few weeks ago, and I had no symptoms really, except my arm hurt for a day or so. Not bad, but I could tell it was there. So it kind of depends on the individual, and it's probably best though to just assume you might get some side effects, and they might be a little bit worse if you have two vaccines at the same time. So I'd probably put a window maybe of a couple of weeks in between vaccinations. Now, how long do you wait if for instance, you've had COVID, before getting a COVID vaccine? I'm not sure if I'm talking to anyone here, but in general, you need to wait, it's probably best to wait about 90 days until you, from the time that you completely have resolved your COVID infection to when you receive the COVID vaccine, for instance. Or the same thing is true if you've had two COVID vaccines or even one, and you then develop COVID, you'd want to wait 90 days before you get some kind of booster. Now, what about, the time you would wait in between getting a COVID booster and Shingrix, et cetera? Shingrix is a little bit different. In general, you want to put a few months in between getting a Shingrix vaccine, the second dose, and getting, say, a flu vaccine or a COVID booster. Now, you could receive a Shingrix vaccine, and at 2 months, then receive a COVID vaccine, and then a couple months later, go ahead and receive the next Shingrix shot. Kind of depends on your own personal situation, but Shingrix specifically, and any other vaccine, you probably ought to allow a couple of months or so. Probably best to even allow 90 days in between the Shingrix vaccine and then any other type of vaccine.
And the mixing of the vaccines, Moderna versus Pfizer, yes.
Yeah, as I alluded to before, the current recommendation is that if you received a Pfizer vaccine, you should receive a Pfizer booster, not Moderna or J&J. And same for Moderna, and same for J&J. Now, there is a small study that suggests no problems with mixing these in various fashions. But I think, it's like anything, we're cautious, we're conservative. We'd like to see additional data to support that. So in general, you want to, if you can, receive a booster of the original vaccine you received. Now, for whatever reason, you just don't have access to receive that particular booster. Then if you say, well, gee, I'm going to wait months and months before I get a booster, or I can just go ahead, if I say had Pfizer and I could get the Moderna right away, can I get the Moderna vaccine? That would not be something that as yet the FDA has recommended. But, kind of be a personal decision on one's behalf. So no untoward effects as far as we can tell, but we probably need just a little bit more data published for us to be completely comfortable to say, sure, you can mix the vaccines.
Okay, so this is vaccine talk A to Z, so I do have 2 more questions coming in. Can you talk about the difference between the regular flu shot and the shot recommended for those over 65?
Yeah. So if you're over 65, your immunity is waning, and it will continue to wane as you get older. So the specific vaccine for those over 65 is stronger. It's a stronger influenza vaccine, and it is made specifically for individuals over the age of 65. And that is my recommendation, that you receive that particular vaccine. I guess one's concern is, gee, might I have more side effects from that? And the answer is almost certainly not. So presently, that's the recommendation.
Any update on the children's COVID vaccine, when it will be approved?
We're really expecting individuals over the age of 2 to 12, or at least 6 to 12, to have approval here any time. Here, our Magna Diaz, our chair of pediatrics here at Bridgeport Hospital, and a professor of pediatrics at Yale, tells me that she's really expecting the FDA to act on this very soon in the form of a so-called EUA, or emergency use authorization. So it could be most any time. I think the big question is, will, like the state of California, the state of Connecticut mandate that children in school receive the COVID vaccine? That actually has already been mandated in California once it's completely distributed. And certainly to those of us who deal with COVID patients on a daily basis, I think that is a extremely wise decision on the part of the people in California. Hopefully, Governor Lamont will follow that course as well.
Do you think COVID will ever be eradicated?
Yeah, if I knew stuff like that, I'd play lotto numbers and win. So I think most experts in the area believe we will never be completely free of COVID, that it might cycle one of 2 ways. One is like influenza, and it varies a bit as time goes on, and then we need to kind of continue to receive maybe annual shots for it. The other other theory I've seen from some experts is that because it's a coronavirus, and because a lot of times as mutations happen, they actually mutate kind of downward with respect to infectivity rather than upward. I mean, we've been beset with Delta variant, but it may well actually mutate kind of downward. And there's very similar coronaviruses like MERS, where that has apparently happened. And so it might evolve into something that's a lot similar to the common cold rather than what it is right now. Now, these are 2 ends of the spectrum. And of course, there's a whole bunch of stuff in the middle. My own feeling is based on what I read, is that it'll be with us for the foreseeable future, and people ought to get used to periodically undergoing vaccination. what I should have mentioned is the mRNA vaccines, the current COVID vaccines, are the most effective vaccines that have ever been developed. And they are probably the safest vaccines that have ever been developed. And this is incredibly exciting to those of us in the vaccine world, because, like, you know, maybe next year the influenza vaccine will be an mRNA type of vaccine. And what will that do? Well, almost certainly it'll make the influenza vaccine more effective than it is right now. Certainly make it a lot easier to make, and you can make it in a much shorter time and then plan a whole lot better, you know, rather than making a guess many months in advance. You know, we can make a guess and apparently turn it over in like 6 weeks. So these are really exciting areas in the area of vaccine technology. So another question, I guess, is why haven't we reached herd immunity?
Yeah.
Which, you know, originally, if you'll remember, I think even an authority like Tony Fauci was saying, well, we got to get, you know, maybe 70% or so. This was based, though, on the original, or what we call wild type COVID virus. And then we kind of readjusted it up into the 80% range or so. And as most of you know, here in the state of Connecticut, individuals over the age of 12 are more than 80% vaccinated. And the whole population is over 70% vaccinated. So again, why haven't we reached herd immunity? And the reason is the Delta variant. The Delta variant is so much more infective. You know, if one person's infected, they're able to pass it on to like 6 other people. We have a certain term for that. What is it for influenza? Well, it's less than 1. So, or around 1. So it's just so much more incredibly infective than the original COVID virus that we saw, that herd immunity is just going to take a bit more than what we got right now to be achieved. Without the Delta variant, we would have achieved herd immunity, I think, so-called herd immunity. But the Delta variant is just so much more highly infective and potentially causes, you know, worse outcomes. That's the problem.
Should vaccinated individuals continue to wear masks?
Yeah. If you're indoors with groups of people, it's best to wear a mask. Probably most of us are used to it. Like if I get out of my car and, you know, I'm walking around outside, I'm like looking, where's my mask? I mean, it's like I'm pretty much used to wearing it. Outside, state of Connecticut, I do not wear a mask. Walking around outside in the state of Connecticut, that would, you know, state of Connecticut is the safest place, #1 in the United States with respect to COVID. But even then, indoors, I go into my local grocery store, I always wear a mask. So if you're in a confined area especially where ventilation may not be great, yeah, I would recommend wearing a mask. The things we have learned are, you know, worry about contracting it from surfaces appears really unlikely. We've kind of evolved to not so much of a worry anymore. The worry is much more about respiratory, you know, contracting it from a respiratory source. So again, wearing a mask in that situation is just, you know, really a good idea. So yeah, I'd say for the time being, until we get to a significantly lower level of percentage of patients or percentage of individuals in the community who have contracted COVID, it really should still be, you should be wearing masks in the indoor settings.
Doctor, I have
Yes.
a different question. Thank you for your delivery, because I've had those shots, everything that you've mentioned, and I'm very pleased that I'm on the right track.
All right.
One of my sons I have 4 adult sons. One of them contracted shingles about 4 or 5 years ago. Should he get the shingles vaccine?
Yes,
Okay.
Yep.
All right. Thank you.
that was an easy one. Any other questions? Any final questions? Nope.
Good. Thank you so much for your time. This is very informative. We will be putting this on our YouTube page, and we'll be sending out our constant contacts. I learned a lot, and we appreciate everything you do for us.
No problem. Thanks a lot, everybody. Bye-bye. Have a good rest of the day.
You too.
Thank you, doctor.